genetic practice that might help them. This is a child you see in your waiting area. You might be a little concerned. She could either have allergic eye disease, that's why she's rubbing her eyes, or she could have something far worse. The far worse thing is what we're interested in. She could have very poor vision. It could be the result of it could be something like ROP, or it could be some retinal dystrophy that makes her feel this way. Her mother is very upset. She doesn't seem to be focusing on her mother's face. She doesn't like the light, and she complains that she's not doing very well at all, and she seems to be poking her eye. Perhaps this gives you some clues. It's a very sad thing for a mom, for her not to be able to have her child look at her face and smile. And what this child has in her retina is very hard to discern sometimes, because the retina may be perfectly normal in a very young baby. So these children who have this rather rare retinal dystrophy, which is the worst kind of retinitis pigmentosa, if you want to translate it in simple terms, presents with nystagmus, strabismus, and very poor pupillary responses, and as time goes by, they have attenuated blood vessels. They could either have hypermetropia or myopia rarely. This is a disease that was recognized a long time ago. Interestingly, it was very heterogeneous, and the ERGs are very diminished. So Leber has his name attached to a lot of things, and in 1869 he was able to discern that it was a heterogeneous disease. We study Mendelian monogenic disease, and this is not one of those, as we've found through the last 10 to 20 years. It is a rare disease. It affects 1 in 3 in 100,000, and only 70% of the patients who have the disease have an identifiable genotype. It's a recessive disease, so it's fairly common in our part of the world, more common in southern India, where we marry our relatives. We even marry our uncles sometimes. So this particular disease can be either syndromic or non-syndromic, something which we've also found out only in the last few years. And it is dependent, how this disease presents, dependent on the mutational load. It could be autosomal dominant in a rare condition associated with a certain particular gene, and it's quite difficult to understand the genetics when you see one particular patient in your clinic, when it's sometimes just sporadic. But always ask the patient if she's born of a consanguineous marriage, if her parents are cousins, and if there are other members in the family who have this disease. Here's a chap I met in southern India. He's 10 years old. He comes from a consanguineous family, and he had profound visual loss since infancy. The parents actually brought the child to me saying he has the same thing that his sisters have, because they have 2 other siblings who have the same condition. These patients sometimes have keratoconus, cataract, and strabismus, and enophthalmos, sometimes rubbing their eyes so much that it looks like it's set far within the socket. And in India, sometimes if you visit a blind school, a lot of patients have Leber's congenital amaurosis. They have keratoconus, and the keratoconus leads to high drops. In high drops, the corneas get vascularized, and when you examine patients in this type of situation, you don't really know what they started with till you ask them a very clear history. The LCA is also associated with Joubert syndrome, which has neurological findings. It can also present with findings, with the epiphyseal findings, as in saldinomencia. It can also have renal complications, as in senior-locan. So in these situations, the ophthalmologist's intention is to find out what syndrome he has, because dysfunctional other organs can kill the child, unlike blindness. So it's important for you to pick this out and make sure the patients have them counseled adequately and their parents seek attention of a medical geneticist, as well as they have their kidneys examined. And if they have a transplant in senior-locans, they're going to live a very long time. The parents will be very unhappy if you didn't pick this up. So those are the overlap of various genes and how these various syndromic things present, because recently you realize that it also affects other organs, as you see in CEP290, which is a gene that causes LCA. So when we started out, we only knew of one gene, and we thought it was a monogenic disease. But in the past 20 years almost, we have more than 20 genes, some which are commonly seen in certain parts of the world and some in others. So typically, you find a gene on a certain location, and what does the gene involve, and what diseases does it cause? So CRX is a cone rod factor, and it can cause cone rod dystrophy, and it can also cause LCA. If you look at this chart, you'll realize that on every chromosome, there are all the little bits of red signify LCA, that you see that all chromosomes, many of them have a little bit of red, which means it tells you where these genes live on the chromosomes. And that's only to illustrate how many genes there are, where they are, and what they do. They affect all levels of visual function, starting with transduction, retinoid metabolism, protein folding, aggregation, trafficking, and neuronal development. More recently, we've been interested in ciliopathies. Ciliopathies relate to the cilium, the photoreceptor cells which connect the outer and the inner segment. When the transport function of this is affected, we have what is called a ciliopathy, leading to LCA, as you will see. And this illustrates to you where these genes are located and how each of these genes have a different number of exons. Sometimes it is just an intronic function that leads to splicing that can cause a gene not to function very well, as it happens in CEP290, which is a very common gene that's mutated in populations in the northern hemisphere. So the LCA genes and proteins, just to tell you a little bit about which functions are affected, for you to think that just a few cells misbehaving can cause blindness in a child. The phototransduction cascade, which we all know quite well, is very important for us, for it to function perfectly for us to see well. The retinoid cycle has become easy for us to understand, and more recently has come into a lot of discussion, because this was the gene that helped us understand how to treat this disease, which is expressed in rods and cones. And that's the sort of small break-off of how genes and mutations in LCA are affected. As you notice, CEP290 is illustrated above, and the other genes in Indian populations may be slightly different. So we are still working on that, and I think Sundaresan does a lot of work on LCA and populations in southern India. That's a small breakup telling you what it looks like in certain countries at a certain time. So it depends where your patient population come from. And because they're all outbred populations in the US, it's very different to that found in southern India, for instance. So the same gene that causes LCA can also cause cone rod dystrophy, and it can also cause RP, as you notice in these numbers listed here. So it's a whole spectrum. It runs from LCA, which is the worst end of the spectrum, to something quite small like cone rod dystrophy. So you wonder what to call it as you see it in this picture. So these are the phenotypes. If you look at them carefully, they all look a little different. So if you are a person who looks into the retina a lot, you slowly learn to identify which genes to screen for, because certain patterns that you see, like for instance a nummular pattern in CRB1, will help you decide perhaps you want to screen that gene if you don't already know which gene to screen for in a child. So here are some pictures which tell you a little bit about that. These are from a friend who also does a lot of LCA, Dr. Kunakoop in Canada. And I studied a large family in western Pennsylvania for a long time, and they had LCA. So here is our group looking at this family who marry their relatives. And they have a very profound pedigree book, so they will be able to tell you who married who and how many children they had, which is very important in genetics. This is LCA5, where the cilium transport is affected. And the birth of the little girl at the end of this page in the 5th generation was what led us to find the gene. And it lives on chromosome 6. Here is an immunopaper showing you how beautiful this protein looked, which we christened lebacillin. So it causes severe developmental disorders in certain groups of people, and it's important to check for photoreceptor degeneration besides the other renal problems that these patients might occasionally have. So the proteome is what we are interested in. And this is a pedigree showing, both neural problems as well as ocular problems in a family. And you might occasionally encounter a patient with Joubert syndrome who has very classical ataxia because their cerebellum are not functioning very well. And as you notice, the whole idea of ciliopathies also runs through a whole gamut of other diseases like Bardet-Biedl, Joubert, and Senior-Loken, and LCA, in addition to Meckel's. So it's important for us to understand not the role of simple genes, but also modifiers and interactions. As you know, lots of these genes interact with each other and they modify disease and they modify phenotype. So it becomes more important for us to understand these. And gene technology, as you know, my colleague mentioned earlier, is genotyping microarray chip technology, which you use. If you first see a patient who comes into your clinic and the parents say to you, well, what are you doing for us? I think then it's not a bad idea to send a little bit of a cheek sample to a lab that will be able to run this chip technology, which has all the known genes of LCA done on it. And then at least on a first pass, you might be able to identify something for this family, because hopefully in the horizon will be treatment and this family might be able to make use of that. So it's important to be able to transfer to our patients, to tell them what's available and what's in the pipeline, because it means everything to them. In LCA, we were able to treat mice, we were able to treat chickens, and then we were able to treat dogs, and that's what made one feel that we should treat humans too. So RPE65 is involved in the retinoid cycle, and we wanted to make sure that we replace the copy that wasn't working very well by injecting the gene into, using adenoviral vectors into the subretinal space, and this populated the retinal pigment epithelial cells. The retinoid metabolism was turned on, and these patients could do better. It was the most remarkable time at Arvo when they showed the patient who could see a little bit after having this test. It was so amazing that the whole audience got up and clapped. So it is an extraordinary moment in time to have somebody who presents with very, very poor vision to be able to see. So the future is getting better, and there is light at the end of the tunnel. So I encourage all of you to look at your patients periodically and examine them periodically, and let's offer them some hope as we get along. In comes this small child with poor vision. The parents said she was absolutely normal, and then one fine day she became slightly floppy, then a little more floppy, and then she couldn't see very well. So what you're looking at in the retina is very classical. She has a cherry red spot, and your heart goes absolutely into the wrong place, and you wish you didn't have to tell the parents that this child was not going in the direction we would like all children to go. So this is a retrograde step for a child who is normal and who then goes downhill. They have psychomotor delay, and slowly they become very unresponsive to time. And the cherry red spots signifies the only normal functioning bit of the retina sometimes. So this child was of Jewish ancestry, and it's not uncommon in some of them to have Tay-Sachs disease. It's a gene that is seen in the Ashkenazi Jews. It's also suggestive of autosomal recessive inheritance, and this family had migrated from Eastern Europe to the United States. So she has a cherry red spot, and as you can see, it's because of ganglioside deposition, all due to the absence of an enzyme that doesn't process gangliosides. Discovered initially by a neurologist and an ophthalmologist, and it's not unusual to see them in certain populations of people, as you see in French Canadians, Cajuns, and Southern Louisiana patients. So the historical perspective is that initially there was a very inexpensive test for this gene, which you could just test for hexa A activity and to replace it. So make sure you get a neurology consult for the patient before you offer a diagnosis, because although you'll do an ERG and do the whole ophthalmic workup on these patients, you want to be doubly sure before you go out and give them a diagnosis. As you see here, the lysosomes are looking quite swollen, and the intracellular transport is not working well. You also have 2 other forms in adults. So there is hope again for this patient. The whole idea is to see patients and to see if you can treat them. So there are things in the in the works. As you see, there's gene therapy and hematopoietic stem cell therapy in the making for this particular disease. So screen your patients, offer them prenatal diagnosis. Some of them even offer mate selection. And currently, I think in the Ashkenazi Jew population in Israel, for instance, all of them are screened for this gene. It is very important. So if you carefully plan, you're going to do quite well. The other disease that I studied for quite a while was nanophthalmos. It's something that you have seen all along in your life because you see patients with very small eyes who show up in all our clinics, but we don't make the diagnosis. We just think, oops, this guy needs very strong glasses. But look carefully, he has an anophthalmos. So you can have both syndromic and non-syndromic, forms of this disease, both autosomal dominant and recessive kinds, sometimes associated with quite prominent retinal dysfunction. Again, there are several genes involved, and look for other things besides looking at the eye because it often has other dysmorphic features. Then you can make the right diagnosis and retinas that look not normal. Here's a pedigree in an autosomal recessive family. Narrow angles, small eyes, choroidal effusions. Your nightmare patient, if you haven't picked her up and you take her to have just ordinary cataract surgery. So it's important to check your patients carefully. This is also a frizzle protein that's not functioning very well in these patients. And there are several kinds. And this is also recessive disease. And these patients get amblyopia. So you want to follow families who have this problem so that they end up having quite carefully planned surgical benefits. So I'd like to thank everyone. And I hope I'd leave you with this feeling that there is possibility of vision. Thank you.